Welcome, everyone. We are going to be talking about Cushing's this evening with Dr. Carolina Arenas, who is one of my colleagues in the internal medicine team. My name is Kate Murphy. I'm the head of teleconsulting clinical services at VET.CT and also one of the internal medicine specialists. Now, VET.CT has three different arms. Carolina, if you want to show the first slide, we have our exceptional teleradiology service. We also have our specialist advice service, and we have an education component. And tonight we're bringing together the specialist advice service, providing some educational support. So with the specialist advice, which is the part that Carolina and I are part of, we essentially provide specialist advice to you in your practices to support you with your cases, helping you to keep the pet and the client with you for procedures and sort of suggesting to you when they do need to be referred. So we're giving you that sort of confidence and support. And what we're able to do is offer 12 to 24-hour written advice in up to 11 to 12 disciplines, but also live interactions with services such as medicine, neurology, oncology, and orthopedics. We also are able to give you multidisciplinary input into your cases. So if you send a case to Carolina or myself through medicine, but we think it needs some oncology input or neurology input, we'll organise that for you as part of the case submission that you've done. And you'll get a nice written summary from us and unlimited follow-up. So we're there basically to help support you to feel more confident in your practice and to provide the best care in the right place for your clients. If you want to get in touch and know more, if Carolina moves to the next slide, then we have a QR code there that you can scan, or you can send me an email at kate.murphy@vet-ct.com, and we can arrange to tell you some more about the service that we offer. So if you can make sure you're muted, you're very welcome to have your cameras on. You're welcome to use the chat, and you can put questions into the chat or the Q&A as we go through the talk. And at the end of the talk, I will manage looking at those questions to give you an opportunity to ask Carolina anything that she hasn't covered in this talk. So Carolina is a graduate from Madrid. She did her residency in Cambridge, and she now works in practice in Spain, as well as working for VET.CT on the specialist advice service. She is an excellent medicine clinician who's published widely in endocrinology, particularly Cushing's, and also leishmania. So she is our queen of Cushing's and leishmania at VET.CT. And I'm going to pass over to Carolina now to tell us a little bit more about Cushing's.
So thank you very much, Kate, for your kind introduction. So we are going to speak today a little bit about the diagnosis and treatment for Cushing syndrome. So Cushing syndrome is a common endocrine disease in dogs, and is caused by chronic exposure to an excess of glucocorticoid activity. So in dogs, Cushing syndrome can occur as a natural condition disease, or it can be the result of chronic exposure to exogenous glucocorticoid administration. It can actually be a challenge in veterinary practice to its wide clinical range of manifestations and potential complications. So cortisol is produced from the adrenal gland, and its production and release is regulated by the adrenocorticotropic hormone in the pituitary gland. So based on the etiology, it can be broadly classified as ACTH dependent and ACTH independent disease. So around 80 to 85% of dogs with Cushing syndrome would have pituitary-dependent disease, and it's mostly caused by a pituitary tumor, which causes autonomous secretion of ACTH. And this is going to cause a bilateral adrenal gland hyperplasia and consequently hypercortisolemia. So 15 to 20% of dogs with Cushing syndrome would have adrenal-dependent disease, and in the majority, again, of these would be caused by adrenal tumor, either an adenoma or a carcinoma. So this tumor is going to produce primarily cortisol, and this cortisol is going to cause a negative feedback into the pituitary and into the hypothalamus. Is going to suppress ACTH secretion, and this suppressed ACTH secretion is going to cause an atrophy of the contralateral adrenal gland. In the majority of the cases, this tumor is a unilateral. However, bilateral tumors have also been reported. So the clinical signs, irrespectively of the etiology, are due to this hypercortisolemia. So this due to this excess of cortisol. It is true that some clinical signs can be very specific due to the tumors itself. For example, dogs that develop neurological signs, or a dog that may actually present with abdominal pain because the adrenal tumor may be bleeding. But the kind of like the common clinical signs that we see are due to this hypercortisolemia. And the clinical signs of dogs with iatrogenic Cushing syndrome are identical from those of naturally occurring disease. So these clinical signs actually develop over months in the majority of the cases. So some owners would actually think that these are the kind of the common aging process and may actually not seek veterinary advice until the clinical signs are more advanced. So the most common clinical signs that we see are polyuria and polydipsia, polyphagia. So polydipsia and polyuria may account or may happen in between 80 to 90% of the cases. Panting, abdominal distension, which is a combination of the hepatomegaly that these dogs have, the large urinary bladder, some fat redistribution into the abdomen. They can also present with endocrine alopecia, which seems to, in the majority of the cases, is bilateral, symmetrical, is non-pruritic, muscle weakness, and we now know that systemic hypertension is very common in these dogs. It may happen in between 70 to 80% of the cases. And actually, it's moderate to severe based on the classification for target organ damage. We can see some other clinical signs that are not so common, such as lethargy, some other skin conditions, such as hyperpigmentation, comedones, thin skin, poor hair regrowth after shaving, for example. And we may actually see some other uncommon but life-threatening complications or clinical signs, such as thromboembolism. We can see on hematology, the most common abnormalities would be a stress leukogram or some part of this stress leukogram. So we can see neutrophilia, lymphopenia, eosinopenia. We may actually also see thrombocytosis. On biochemistry, the most common abnormalities that we often see are elevated ALP, elevated ALT. We can also see hypertriglyceridemia, hypercholesterolemia, but these are also common in some other endocrine diseases such as diabetes mellitus or hypothyroidism. And although hyperglycemia is quite frequent or common in these dogs, overt diabetes mellitus together with Cushing syndrome is not so common. So it may actually happen in around 13% of the cases. On urinalysis, we see this non-properly concentrated urine, as we have seen that the great majority of these dogs present with polyuria and polydipsia. The urine could be isostenuric or hypostenuric also, the proteinuria, which tends to be mild or moderate. And we may actually see also some indicators of urinary tract infections, such as hematuria or pyuria. So the decision to pursue endocrine testing should be based on clinical suspicion. So this includes a compatible history, physical examination findings, and laboratory abnormalities. So we actually don't test just based on as isolated clinical pathological abnormalities. So meaning that we tend not to test in these dogs that actually have just an elevated ALP on clinical pathology without clinical signs, because actually the lack of clinical signs should lower our suspicion for Cushing syndrome. In other words, we tend not to screen for Cushing syndrome. We tend to test or investigate when the clinical picture justifies it. Based on the consensus statement, which was published also a few years ago, there are some other scenarios for which we can also pursue endocrine testing. So this is, for example, the presence of a pituitary macrotumor or an adrenal gland mass on imaging studies, as we actually need to know whether these tumors are functional or non-functional. If we do have, for example, a diabetic dog which is insulin resistant, and when we do have a dog with a persistent hypertension for which we haven't identified a concurrent disease which justifies the hypertension. In any of these cases, dogs should not be on glucocorticoid treatment, neither topical, neither systemical, because these glucocorticoids are going to suppress the pituitary adrenal gland axis and are going to make the test very difficult for interpretation. So a few years ago, clinical decision-making has been supported by the development of some clinical tools, which actually gives us the predictive or the likelihood of a dog having Cushing syndrome before pursuing endocrine testing. So this is the Canine Cushing Clinical Score tool, which works by assigning some points to the most common signal and clinical signs and not so common clinical signs, and actually gives us a total score. And based on this total score, it would give us the likelihood of Cushing. So this predictive tool does not eliminate the need for endocrine testing. So actually, if the diagnosis is made on endocrine testing, but actually may help us in some cases to decide whether we need to pursue endocrine testing. And I've brought you a couple of examples. So this is Tiggy, an 8-year-old military crossbreed dog whose main concern is polyuria and polydipsia. It does not have alopecia nor abdominal distension. It has a urine-specific gravity, which is consistent with that polyuria and polydipsia reported by the owner, and it has an elevated ALP. And we have identified an abdominal ultrasound and splenic mass and bilateral adrenomegaly and urolithiasis. So we put the signalment here, we put the clinical signs that we have. It does not have pruritus, no alopecia, and everything. It gave us a total clinical score 2, which gave us a likelihood of TG of having Cushing syndrome of 53% chance. So actually, it's not very high. So probably in TG's case, we should probably exclude or rule out other causes for polyuria and polydipsia before pursuing endocrine testing. Whereas if we have Toby, so again, the same signalment, the same clinical signs, but this case we have abdominal distension, as we can see on the picture. It has the non-properly concentrated urine, the same clinical pathological abnormalities and abdominal ultrasound. And if we put all of this information together, it gave us a total score of 5, which gave us a likelihood of a 78% chance of Toby having Cushing syndrome. So in this case, probably the next steps would be to pursue endocrine testing. So as you see, the clinical tool does not eliminate this need for pursuing a low-dose dexamethasone suppression test or another test, but it helps us in some cases on deciding whether we should go on the right direction or on the direction of testing for Cushing or not. And why this helps us? Because we have several tests, so some endocrine tests for the diagnosis of Cushing. So, and we know from the consensus and also these recent guidelines that were published a couple of years ago that the tests available that we have for the diagnosis of Cushing do not have 100% diagnostic accuracy. So this means that the test can yield false positive and false negative results. So actually, we need to properly select our patients in an attempt to try and minimize the possibility of these false positive and false negative results. So especially when we do have dogs with concurrent non-adrenal illness, we should try and attempt to stabilize them first before, or try to resolve them before pursuing endocrine testing, because this when we do have a concurrent illness, the likelihood of a false positive test is higher. So the low-dose dexamethasone suppression test is the most common recommended test to test for diagnosis for Cushing syndrome. So the test relies on assessing the response of the hypothalamic pituitary adrenal gland axis to the negative glucocorticoid feedback. So in dogs without Cushing syndrome, administration of dexamethasone is going to cause a suppression of ACTH, and this suppressed ACTH is going to suppress cortisol production or secretion over at least 8 hours, whereas dogs with Cushing syndrome are abnormally resistant to this negative feedback. So the test can be studied at any time in the day. So fasting is not essential, but actually is recommended to avoid feeding during the test because actually lipemia can interfere with some cortisol assays. So for the test, we take bloods for cortisol concentrations, either serum or plasma, just before and 4 hours and 8 hours after administration of dexamethasone intravenously, so 0.01 milligrams per kilogram. And we are going to use mainly the 8-hour results for the diagnosis of Cushing syndrome. So in the kind of like the threshold for cortisol for interpretation lies between 28 and 38. But actually, we should use the laboratory cutoff values of the laboratory that we are using. So meaning that we should actually not look into books for actually giving a cutoff value for the test. We should use a specific laboratory values for interpretation of the test. So dogs without Cushing syndrome would actually have a cortisol for 8 hours, which is below the cortisol cutoff value, whereas dogs with Cushing syndrome would have the cortisol at 8 hours above this cutoff value. In some cases, the low-dose dexamethasone suppression test is actually going to be able to differentiate in between dogs with PDH and ADH. So in some cases, we can see that there is more than 50% suppression of cortisol values at 4 and at 8 hours in comparison to basal cortisol, so the cortisol at 0 hours. And this is called a partial suppression. So we see 4 hours and 8 hours, which the values are above the cutoff value for the cortisol, but more than 50% suppressed. And this is consistent with PDH. We can also see what we call an escape pattern. And in these cases, we see that the cortisol at 4 hours falls below the cutoff value for the interpretation, but at 8 hours rises again. And this is also consistent, and we can see it in dogs with PDH. In some cases, very, very small cases, but we can also see what is called an inverse pattern. The inverse pattern consists the 8-hour cortisol concentrations is below the threshold for the cortisol, so actually would not be consistent with Cushing syndrome. But at 4 hours, we see that the cortisol rises above the threshold. So this inverse pattern is not consistent with Cushing syndrome. We actually need to pursue further testing, but it's actually very suspicious for PDH. So in these cases in which we see, for example, an inverse pattern, or in this case in which the cortisol at 8 hours is in this kind of gray zone, borderline, and is not completely positive or suggestive of Cushing syndrome, but we still have clinical suspicion for Cushing syndrome, either we repeat the test in 2 or 3 months, or whether we move on and perform a different test, because again, we know that this test can yield false negative results. So if we do have a high suspicion of Cushing syndrome, we should pursue further investigations. If we see what we call a lack of suppression, so meaning that the cortisol at 4 hours and at 8 hours are kind of like similar to the cortisol at 0 hours, we cannot differentiate in between PDH and ADH, because some dogs with PDH actually do not suppress at any time. It is important again to recognize that the test is very sensitive, but it's not so specific. So meaning that if in a very stressful dog, or in dogs that have concurrent or non-adrenal illness, we can have a false positive result. So a second test that we can use is the ACTH stimulation test. So the test assesses the adrenocortical reserve and is the gold standard for diagnosis of iatrogenic Cushing syndrome. The test seems to be less impacted by stress and non-adrenal illness, so probably is the test of choice in these dogs with concurrent illness, in which we want actually to rule out the possibility or diagnose the Cushing syndrome. So, for example, with the test, the ideal test to perform in those diabetic dogs that are resistant to insulin and in which we actually want to rule out Cushing syndrome. The test lacks sensitivity in some cases, and especially in dogs with ADH. So meaning that if we have a dog in which we have found an adrenal tumor and we actually want to investigate whether the tumor is cortisol secreting or not, we actually would need to perform a low-dose dexamethasone suppressant test and not an ACTH stimulation test, because the likelihood of a false negative is very high. So differently also to the LDDS test, the ACTH stimulation test that is not able to discriminate or to differentiate between PDH and ADH. So for the test, so the same recommendations as I've said for the low dose dexamethasone suppression test. Bloods are taken before and 1 hour after synthetic administration of ACTH, and we now recommend to a dose of 5 micrograms per kilogram of ACTH to try to minimize the complications associated with the ACTH administration. The third test that we have is the urine cortisol to creatinine ratio, which is a measure of cortisol production over time. So ideally, we use the first urine morning sample. So in this way, we can assess actually cortisol production over the last 8 or 6 hours. So until the last voiding of urine in this dog. The test is very sensitive, but actually the specificity is very poor. So meaning again that dogs with concurrent illness can actually give us a false positive result. So nowadays, this test is mainly used in those dogs in which we have some suspicion for Cushing syndrome, but our suspicion is actually not very high, and we want actually to rule out Cushing syndrome from our differential diagnosis. So it's not a recommended test for when we have a high suspicion for Cushing syndrome. Ideally, the urine sample should be collected at home to try to minimize the stress, and at least 2 days after a stressful event. So diagnostic imaging is also very helpful in discriminating dogs with PDH and ADH. So in dogs with PDH, we're going to see these bilateral and symmetrical adrenomegaly, and we can see that the adrenal glands kind of have maintained architecture. Whether in dogs with ADH, we would see a unilateral in most of the cases, adrenomegaly or an adrenal mass, and the contralateral adrenal glands would actually be atrophied, and kind of like the most common recommended kind of cutoff, but this atrophy would be 5 millimeters in diameter. So diagnostic imaging is also helpful, for example, to screen for thoracic metastases in case in which we have identified an adrenal mass, or for some specific scenarios, for example, dogs that develop neurological signs in which we want to rule out the possibility pituitary macroadenoma, and also for screening some comorbidities that we know that are common in dogs with Cushing syndrome. So the treatment would actually depend on the etiology. So the most commonly used treatment for PDH is trilostane, whether the recommended treatment for dogs with adrenal-dependent disease, so for dogs with adrenal tumors, is adrenalectomy. In those dogs in which adrenalectomy is not an option for whatever reason, we can still use trilostane with the kind of like the same aims to reduce the hypercortisolemia and the complications associated with it. So going to trilostane. So trilostane is a reversible enzymatic inhibitor of steroid synthesis in the adrenal glands. So it actually reduces aldosterone concentration, cortisol concentration, and also can block or reduce sex hormone production in the adrenal glands. So the medication, so trilostane can give it once daily or twice daily. We know that it may actually not impact a lot on the endocrine test that we are using, but from several studies, we know that the clinical pictures or the clinical signs are much better controlled when we give it on a twice daily dose. Nowadays we also use or start on a lower dose, and depending on efficacy and how the clinical signs are controlled, and so we can actually increase the dose as needed. But we tend to use in a lower dose, and actually some recent studies have found that even starting with lower doses, we can have a very good survival time in these dogs. It is normally given with food to try to enhance absorption. So why do we monitor dogs on trilostane treatment? So there are three main reasons to monitor these dogs. So the first one is to improve the quality of life of these dogs and to try to control signs. And actually, one of the ALIVE goals of treatment, and ALIVE is a project by the European Society of Veterinary Endocrinology, is not only to control clinical signs, but to eliminate clinical signs. And actually, this should be our focus. Our main goal when we are treating with trilostane these dogs is to control or to eliminate clinical signs and to improve the quality of life. And this is actually the best way of assessing if the treatment has good efficacy or not. And we now have very good tools to objectively assess the quality of life, not only of our owners, of our dogs, sorry, but also of our owners, because actually Cushing syndrome is a disease that actually impacts on quality of life of the tutors themselves. And we also have some tools to objectively determine whether we are improving the clinical signs. And we should not only focus on the basal clinical signs, because that is kind of like easy, but we should actually monitor evolution in comparison to last reevaluation. So these kind of charts that we can use are very useful and help us assessing in an objective way whether we are having good control of the disease. The second reason to monitor trilostane treatment is to try or to anticipate to complications associated with Cushing syndrome. And this was one of the largest studies assessing comorbidities in dogs with Cushing syndrome. And we know that some of these are diabetes mellitus, urinary tract infection, and thromboembolism and urinary lysis. And from this study, we actually also know that 50% of dogs, so 1 out of 4 dogs, would actually be euthanized due to causes directly attributable to Cushing syndrome. So actually, if we are able to control clinical signs, if we are able to control or to try to avoid or to anticipate these comorbidities, we may actually be able to improve the survival for these dogs. So one of these comorbidities that we tend to forget about is systemic hypertension. And we have some studies recently assessing not only the incidence of systemic hypertension in these dogs, but also what happens with systemic hypertension during trilostane treatment. So again, we know that it's very common at diagnosis. Up to 80% of dogs can present with systemic hypertension, but we also know that despite trilostane treatment, they can have persistent hypertension. And the majority of these dogs are actually going to need treatment for hypertension apart from trilostane. So apart also from assessing and monitoring clinical signs and cortisol concentrations by the means we use, we should also be assessing comorbidities, and we should also be rechecking blood pressure in every single reevaluation. And we actually know that the development or resolution of systemic hypertension is not related to a good clinical control of the disease. So this means actually that we can have a dog that is perfectly controlled, no polyuria, no polydipsia, and having systemic hypertension and even severe systemic hypertension. So this should also be monitored in every time. And we also know that some dogs that are normotensive at diagnosis can develop, despite trilostane treatment, can develop systemic hypertension. So because we know that there is a risk for target organ damage, we should also monitor apart from monitoring cortisol itself and clinical signs. The reason to monitor trilostane treatment is to try to limit side effects associated with the treatment. And we know that hypoadrenocorticism is one of the signs associated with the treatment. So there are several studies already assessing hypoadrenocorticism, and we know that this can be transient, but it can also be permanent, which actually is not very is not what we expect for a drug that has that is a reversible enzymatic inhibitor. So we should also watch for the potential of developing hypoadrenocorticism. From this study, we know that actually the incidence increases with risk. So meaning that the longer a dog has been on trilostane treatment, the greater possibility that has to develop hypoadrenocorticism. Actually, the incidence at 2 years. So if a dog has been on 2 years on trilostane treatment, it may have actually a 15% chance of developing hypoadrenocorticism. And we actually know that the risk is not associated with the dose rate, meaning that we can have a dog on a very low dose of trilostane, and despite being on a low dose, it can also develop hypoadrenocorticism. So actually monitoring should be done frequently, and the longer a dog has been on trilostane, the longer we should, or more focused probably we should be on the potential for these side effects. So how do we monitor and when do we monitor? So we assess these dogs at 10 days and 10 days after every dose adjustments. We also monitor 1 month later and then every 3 months. That would be the recommendation. And there are several ways of monitoring cortisol concentrations. In any case, we need actually also to monitor clinical observation via the scoring tools that we have already. So the most common tool that we have now for monitoring trilostane treatment is the pre-trilostane or the pre-pill cortisol concentration. And we know that this correlates very well with clinical control. And when compared with the post-ACTH cortisol concentration and the basal cortisol, so this would be a cortisol taken 3 hours after trilostane treatment, from several studies, we know that the pre-pill trilostane is the better, that is able to discriminate in between dogs that are having excellent control or that are not well controlled. And the trilostane cortisol seems to be more useful at potentially or signaling potentially over suppression, because when we were running the ACTH stimulation test to monitor trilostane treatment, we tended to use it at peak effect of trilostane. So actually, when we were using the test at peak trilostane effect, it could actually put in or point over suppression in too many cases, and seems that the pre-pill cortisol does not signal over suppression in too many cases. However, and despite knowing that it seems to be better to discriminate these dogs and is well correlated with clinical signs, is not perfect at all, and we know that there can be discrepant results, meaning that I can take a pre-pill today and a pre-pill tomorrow, no changes at all with the medication, and would have discordant or discrepant results, and so discrepant that actually could yield to different therapeutic recommendations. So we actually need to take into account these. So we have some kind of like charts or recommendations, so guidelines to try to help and our decisions. So if we do have a dog that is well clinical controls, does not have polyuria polydipsia, we know that we have a pre-pill cortisol target range. So in this case, we would not make any change or any dose adjustments. If we do have a cortisol, a pre-pill cortisol, which is above the kind of like the target range, we could reevaluate the dog because it's having no clinical signs and is well controlled. Or we can actually think, if it's on once daily treatment, to try to split it in twice daily, or to increase a tiny bit the dose. If we do have a well-controlled dog, a very happy dog, but it has a cortisol prepill which is below the cutoff value, we should either reevaluate the dose or lower the dose. If we do have a dog with clinical signs of Cushing syndrome, no matter maybe what is the cortisol, so no matter where the cortisol is, we actually need to increase the dose or the frequency of this dog, because the aim of trilostane treatment is to eliminate clinical signs, to control clinical signs. So actually, probably not that I don't care, but no matter whether the cortisol is, this dog needs actually an increase in the dose. The scenario, though, the different or the distinct scenario would be this dog that has clinical signs of Cushing syndrome, but it has a prepill cortisol that is below the cortisol target range. So in this case, we should probably look for other causes of polyuria polydipsia, or reevaluate the case, or run an ACTH stimulation test to see what is happening, or actually may seek advice. So we may actually have also dogs that are clinically unwell, so in poor health, so maybe lethargy, abdominal pain, whatever. In these dogs, we need to stop trilostane. And from here, the prepill cortisol is not useful with this scenario. We actually need to move on to run an stimulation test, because we actually need to know whether this dog is feeling unwell because it has hypoadrenocorticism, or is feeling unwell because of some other complications or other disease. So we can still use the ACTH stimulation test, and there is a good gap for this test. So this test was the test that was used historically for monitoring dogs with Cushing syndrome. We have not used it in the last years because the lack of ACTH in some countries, and also because from several studies, it seemed that it's less correlated with clinical signs than the prepill cortisol. But there is still controversy at what time in we should perform the ACTH stimulation test. But it's a test which is very useful in some of these scenarios that we have seen. So in those cases in which the clinical picture does not fit with the cortisol prepill, and probably in those in which the cortisol prepill is very low, and actually we want to rule out that we do not have a hypoadrenocorticism, or in those unwell patients when we want to actually rule out that they are feeling unwell because they do have hypoadrenocorticism. Any case, it doesn't matter really if we are measuring cortisol prepill, if we are running an ACTH stimulation test, we can never, ever use this test to guide our treatment. So either the cortisol prepill, either the ACTH stimulation test are tests that are going to help us taking the decision, but we are always going to have a good look at the clinical picture, looking at the dog, looking at the physical examination findings, look at the laboratory abnormalities. We are going to almost have 80% in our mind what we are going to do with the test, and probably we are going to use the prepill or the ACTH stimulation test to give that little of confidence of what to do with the dose. But again, the cortisol prepill and the ACTH does not replace clinical judgment. And with this, I hope that you find this webinar useful, and I'm happy to take any questions that you may have.
Great, thank you for that, Carolina. That was fabulous. If you have any questions, please feel free to just put them in the chat, or you can type them into the Q&A. And we do have a couple of questions so far. So Carolina, the first one is one of the ones that challenges a lot of people in practice. You've got a patient that you think might have Cushing's, but it's been on steroids, and you want to test for Cushing. So how long are you going to wait? Or actually, can you test while it's on steroids? Let's put that one in first.
So no, I mean, if we are testing for Cushing, we cannot test when a dog is on steroids, because these steroids are going to suppress the pituitary, hypothalamic pituitary adrenal gland axis. So actually, first, we are not going to be able to interpret the results of the test, but also depending on the steroids we are doing, actually, that is going to interfere with the cortisol assay. So it is going to be a nightmare to interpret the test if a dog is on steroids. The second one is how long should we know to stop steroids before running the test. And I don't think that there is a good answer for this. And but at least the kind of like common recommendation would be to at least to stop steroids for at least 2 weeks. Sorry. It also depends on how long a dog has been on steroids, so and what type of steroids it has been the dog on. So whether it has been on short course durations, or is on long-term effect. So for such as, for example, triamcinolone. So we should also take into account the longer a dog has been on steroids, probably the longer that we need to stop steroids. But the minimum I would say would be 2 weeks. And again, there is this common kind of like knowledge or thought that topical steroids would actually not interfere with the test, and that it would not matter. So there are several studies already there actually looking at autotopical administration, ophthalmological administration of steroids, and we actually know that even being topical, they actually also, not as much as systemic for sure, but they also actually suppress the pituitary adrenal gland axis. So even though if it's topical, we should stop treatment at least for 2 weeks.
Fantastic. Yeah, I completely agree. And I think the longer, I guess my approach has always been Cushing's is unlikely to kill them.
Yeah.
And so if we want to get a reliable test, the longer we can keep them off, the better.
Yeah.
So
for
you
sure.
mentioned with treatment that we obviously can go once a day or twice a day, and that we've got the sort of, I guess when the drug first started, it was closer probably to the 2 mg per kg that people were dosing, but then we've got the lower dose recommendations. So if you've got a compliant client, what would be your favorite starting dose? Would it be low, high, once, twice a day?
So I would normally now use very low doses, so that would be 0.51 mg per kilogram twice daily. And I go always twice daily, so it's not that I don't give them a chance, but I don't know, 98% of the cases will actually start on twice daily, because we know already from several studies that actually trilostane does not last for very long. So in many dogs actually do not even last for 8 hours. So there is going to be a very long hours during the day, every single day, in which, as long as the trilostane is weaned off the system, as it's a reversible enzymatic inhibitor, hypercortisol is going to be produced again. So we are going to have 3, 4, 10 hours, 8 hours in which hypercortisolemia is going to be also produced. So this is the reason why in these dogs, clinical signs, or in dogs with once daily treatment, clinical signs are worse control and not as better control as on twice daily. So I tend to start always twice daily in low doses.
Brilliant. Okay. And you mentioned the controversy about if we're going to use ACTH stimulation tests for monitoring, about the timing. So do you have a sort of preference for when you would do that as a monitoring test?
So yes, that is a very good question. There is a lot of controversy around that. So when using for monitoring, the kind of like the guidelines state to do it between 2 and 6 hours. a probably different scenario would be that dog in which you actually want to rule out hypoadrenocorticism because it has, for example, a pre-pill which is low. I think in these cases, it's not very intuitive to perform the ACTH stimulation test, a peak trilostane effect, because at peak trilostane effect, we are going to have the lowest cortisol concentration along the day, but that does not mean that the cortisol cannot rise 2 or 3 hours later. So if I want to rule out kind of hypoadrenocorticism in a dog that is on trilostane treatment, I probably would not do it at a peak trilostane effect. But this is kind of like some, well, personal and it's nothing kind of actually written, but it's my personal approach, actually.
Okay, that's really interesting. A couple more questions. You mentioned, obviously, when you were talking about the low-dose dexamethasone suppression test, that in some situations it can differentiate between adrenal-dependent and pituitary-dependent disease.
Yeah.
If you've got a client who has said they're only interested in medical treatment, do you think there's any need for us to try and differentiate, or should we just get on and treat?
I think it's not going to change our treatment decision, but probably it may actually change the prognosis. So if we do have, for example, an adrenal tumor, carcinoma, or an invasive tumor, or it can bleed, it can burst, it can cause hemoabdomen, it can invade vessels or metastasize. So I guess from that point of view, not from probably a medical point of view, but from a prognostic, yes, I think that we should probably try to differentiate.
And you sort of mentioned imaging. Is that the main way you would use to differentiate these days, or do you still sort of do the high dose DEX or endogenous ACTH measurement in any patients?
I use imaging these days. I think it combines perfectly assessing for comorbidities and differentiating. I cannot remember when was the last time I used a high dose
No, no me.
dexamethasone suppression test. So I think it combines and it gives like not just one information, but it gives broad information about these dogs that do have a lot of comorbidities.
Yeah, absolutely. So another sort of thorny issue that I guess we come across relatively often is the patient that is a diabetic and has some enzyme changes that could fit with Cushing's, but could just be its diabetes. So when would you say to people that it's worthwhile starting to think about investigating Cushing's in a diabetic? How much should we try to stabilize before we get there?
So I get that a dog on ketoacidosis is not the proper moment to to test for Cushing syndrome, I would say. If it has some clinical features of Cushing syndrome, such as bilateral alopecia or distending abdomen, thin skin, and some kind of more specific clinical signs of Cushing syndrome, I think we could wait to stabilize the diabetes, but probably not much, because it's going to be very difficult to stabilize the diabetes mellitus if he has persistent hypercortisolemia. But I guess that in these dogs, if we have a high suspicion of diabetes, we could probably put up our doses of insulin and see whether we actually are able to control the disease or the diabetes with a high dose of insulin. And if we are not able, then to test for Cushing syndrome. Now that I would just go and give them one unit twice daily, but probably these are the dogs in which we can escalate the dose a little bit faster than in a normal dog. And then if we are not able to control the diabetes or the hyperglycemia, then to test for Cushing.
Fantastic. Well, my sort of, I was looking at your CV and you qualified in 2003, correct?
Yeah.
So that's when I got my diploma. So that made me feel quite old when I was looking at that. But in my residency, which was a few years before that, that was when we first started using trilostane to treat Cushing. So I was from the mitotane generation.
Yeah,
So
so was I.
trilostane has completely changed treatment of Cushing's, and I think gives us so many better options for getting good stability in these patients.
Yes.
But as you've shown us, we still have those diagnostic dilemmas as well to face. So thank you for talking us through that. I've got one more question that's just come in. So question is if a patient has both Cushing's and diabetes, which one would you treat first?
So it has both. I would
Yeah.
treat both. So I don't think there is a need to wait for. So I don't think that we should trade one first and the other. So I would trade both. Just knowing that if you start treating for Cushing with trilostane, you are going to reduce hypocortisolemia, so you are going to reduce your insulin resistance. So probably this dog is going to need lower doses of insulin. So this does not necessarily mean that I would not treat them both. So I would treat them both, but probably I would treat them both. I think diagnosing at the same time diabetes and Cushing is a challenge unless a dog has like typical Cushing clinical signs. So this pot belly dog with alopecia, bilateral symmetrical thinner skin that develops also diabetes mellitus. That would be kind of like the only scenario in which you would actually diagnose both at the same time. But I don't think that we need to wait for one and the other. Just the highlighting that as soon as you start treating or reducing the cortisol concentrations, you are going to reduce your insulin resistance, and that diabetic, if it was on, for example, 8 units before, you would actually risk of some hypoglycemia episodes. So you probably need to lower your insulin dose once you start treating with trilostane in these dogs.
Yeah, absolutely. And I guess these are the great ones where having something like the Freestyle Libre on really helps us for identifying those risk periods and being proactive and managing them. That's brilliant. You've answered all the questions that we've had tonight. Could I ask you to move on to the next slide?
Yes, sure.
Fabulous. So we have some more webinars coming up. If you want to click on the QR code with your camera, then you can register for more. And if you want to know any more about the specialist case advice, feel free to reach out to me via email. And we're very happy to sort out giving you some further information on that. So it just leaves me to thank Carolina for a fabulous presentation and to thank you for attending live, or for anyone who's going to watch on Team Replay. Thanks for joining us, and hopefully you'll join for our webinars soon in the future. Have a good rest of your evenings.
Thank you very much.
Bye all.
Bye.